this is the ASMR Medic, and welcome back to another revision session, a medical revision session. I am a qualified and working doctor in the UK. I'm happy to be able to now say that. I've been working for just under a year in the UK in the NHS, and you're going to join me on a revision session, or a learning session really. So in just under a year's time from now, so quite a while, but I like to get ahead of it for reasons that I will go into soon enough. I will be sitting this examination, the multi-specialty recruitment assessment, or MSRA, and is the exam that doctors in the UK need to sit in order to rank for placements for several specialties. Off the top of my head, I think it's general practice, pediatrics, psychiatry maybe. It might also be for emergency medicine as well, and acute care. I'm actually not entirely sure. There's also MRCP, which is for the surgeons. I think I should probably know a bit more with more certainty. The main thing that I know is that this exam is it's 100% for GPs, which is what I am most interested in. I want to go and be a general practitioner, working in a general practice. And I think it's also for paediatricians, and I'm also quite interested in paediatrics. So you do this exam, you get your score, and that ranks you alongside all the other specialty applicants for that year. And that, the better you do, the more kind of freedom you have to go wherever you want to go. And I'd quite like to be placed in London, which is, surprise, the most highly or in high demand area, or most competitive area, which is not good, which means I need to get ahead of it a little bit. I've always been more of a hands-on kind of learner. I'm not massively academic in that sense, and so I was pretty bang average at medical school. I could never do those sort of 4, 6, 8 hour, 10 hour revision sessions that some people, a different breed to me. I don't know how people do that. I've never been one to do that. So I wasn't able to get the competitive grades enough to secure a place in London, and so I'm currently training outside of London. Still in a place that I really, really like, not too far away from London, but it is what it is, But it just goes to show that your performance is absolutely vital to giving you the sort of freedom that you need. And so I've set out a bit of a revision timeline for myself, which hopefully you guys will be able to join me on over the next year, which is going through all of these sorts of questions and revision resources, specifically something called Pass Medicine. This is the website I'm using now. Medical students use it. Obviously trainees like myself use it, and specialty trainees use it as well for their various exams. Huge bank of questions that you can use, and I'm not doing very well at the moment, as you can see. I think I'm averaging something like 49.5%. It's pretty bad. I've mostly focused on surgery. I've almost completed the surgical questions. That's because I'm currently on my surgical rotation. Started last week. So I was trying to brush up on a few things. I say brush up, I was trying to learn. This is as a renoprotective agent. Lisinopril has been titrated up to treatment dose. The current plans are as follows. That's kind of a bit, but I mean, hard to say really from 3 months to now. Could just be daily variation. Creatinine up a tiny bit as well, and I guess overall the picture is a worsening renal picture though, isn't it? I mean, it's so small. Of the following options, what is the most appropriate course of action? Stop lisinopril and arrange investigations. Stop lisinopril. Well, ACE inhibitors. Shit. I thought ACE inhibitors could actually damage. I thought they were renotoxic in some situations. Switch to angiotensin 2 receptor blocker. Switch to a different ACE inhibitor. Well, we don't know how her hypertension is going. No action. Reduce the dose of lisinopril. God, I really don't know. Exclude renal artery stenosis. Act as a renoprotective agent. Gosh, I actually really don't know. I really don't know. I just want to make sure I'm still recording. Yes, we're all good. Switch to an angiotensin. I mean, not much has really changed. I guess it's kind of everything has gotten a little bit worse. Switch to a different ACE inhibitor. Act as a renoprotective agent. Well, because you're reducing hypertension, then technically you're doing that. But now, I am sure they're that they are. I'm sure that they are. Maybe switch to an angiotensin 2. Are they also? I don't think they are. Am I screwing this up? I keep opening my like AirPods and I see my phone is like flashing because I think it's the notification, but I want to say switch. Christ almighty. The small change. Oh, this is the thing. I said that there's a small change. Fair enough. Usually I would copy and paste all this and like go through it on my Notion, but I can't be bothered right now. Chronic kidney disease. Majority of patients. Okay. Tend to reduce filtration pressure as well. A decrease in eGFR up to 25 and 30% is acceptable. See what people are saying. I wasn't really focusing on that. I was focusing on the fact that, like, my rationale was because you're trying to guess what he's getting at. Because logically, yeah, I guess no action, small increase, small increase, small increase, or like small worsening. Like that's gone down, but that's gone up. But it's both renal, like worsening renal function. And I thought if it was one of them, then the rest were the same. Like I would have just thought like variation, but they have all gotten worse. he's not producing enough protein, is he? That's what's going on. He's not producing enough protein. Because his liver is failing. Which is causing him to lose fluid because he's got a reduced oncotic pressure. That's what's going on, right? Fluid sample collecting. I don't know. I'm sure that directs us somehow, but spironolactone to get rid of the fluid. Maybe, I don't know. Azathioprine, terlipressin. I feel like you do give this in these sorts of patients, but I don't know what the thing is. Ciprofloxacin. I don't know why you would do that. Prednisolone. Is there an inflammatory thing going on? I suppose there is, but is that what's driving this issue? I don't think so. Do you really want to offload fluid in that way from somebody like this? I don't think you do. Azathioprine. What does azathioprine do again? I think it's another immunosuppressive. I'm going to say terlipressin because I know that is kind of What's particularly disappointing is that so many people are getting it right. Ascites, spironolactone is my first bloody thing and I changed my mind again. Lack of knowledge, that's what it is. which of the following is most consistent with the which of the following is most consistent with the diagnosis of acute tubular necrosis? I hope they were going to say like muddy brown casts or something, but no. Acute tubular necrosis. Not necessarily. Not necessarily. So it is, necrosis of the tubules. Urine osmolality. I'm trying to think logically. If you had raised urinary sodium, would you not expect it to be lowering in terms of serum? Sorry, I cut there not to Google it, so that I don't look so stupid. I promise I'm not going to do that. There is the bin men van thing has come up and down the road 3 times. Why? I don't know. Doing their job obviously, but I don't understand why. I've got nowhere with this. I can't remember the pathophysiology of this. Like, if the tubules are necrosing, would that lead to more, like you're losing sodium or retaining sodium? I mean, looking at this, sodium is on the slightly high side, so maybe low urine sodium, but on the other hand, you get reuptake of hydrogen and sodium, and I can't remember where that happens. Does that happen in the distal tubule? I think it does. So in that case, would you have raised sodium because it's not being reuptaken, I suppose, but then I don't understand what the significance of this is. Okay, fine. Yeah, I mean, complete luck. I had no idea. I really had no idea. Low I was going to go for purely based on these. I bet this is going to say, why is it sodium low? Okay. What did this person say? ATN, all the NA, high NA, everything else is low. Pre-renal, urine, low NA, everything else high. Yeah, I'm happy with this. Damage to tubular cells. Yeah, I'm fine with that. Okay. Acute tubular necrosis versus pre-renal uremia. Osmolality is low with that. What is osmolality again? What the hell is osmolality? Is that like the potential for it to, like it's ionic potential, I suppose? What is osmolality? Osmolality is a measure of concentration of solutes. Particles can be ions, molecules. question, isn't it? So I'm tempted to go with one of these, but I'm more tempted. I would say the carbon dioxide retention. He's not retaining, although. Okay, let's think about this logically. Bicarbonate is going down. He looks septic, doesn't he? I would say lactic acidosis is probably the cause. Very high lactate. Although, I mean, you can have, again, acute tubular necrosis can lead to acidosis, but chronic kidney disease 1 suggests this, though. Why would you immediately think this? This is just everything I'm seeing is a doxycycline given by basal crackles as well. Sounds like he's got fluid. Doxycycline, has that been given for a UTI, in which case acute kidney injury is reasonable. Bicarbonate is low. Basic says is very low as well. I mean, is that lactate is pretty high. But now I'm tempted to go for acute kidney injury because I know it's a nephrology question. Like, why else is this in the nephrology section? Like, why is that? Why is this in nephrology? Because of the aldosterone stuff. Would I actually go for AKI? Would I actually go for AKI? Why would it be AKI? How could it be AKI? It could be AKI. AKI could be causing it. Well, why? His temperature is 38.9. Look, this is sepsis, right? This is sepsis. So therefore lactic acidosis surely is the cause. Acute kidney injury, I suppose, yeah, can cause it. I'm going to go lactic acidosis. Okay, thank God. Why is this in nephrology? My thinking there is that, like, question. I don't know. Whatever. A 33-year-old pregnant woman presents for advice. She is known to have polycystic kidney disease but is currently well. Her father also has polycystic kidney disease and is on dialysis. What is a chance a child will also... Is it not just autosomal dominant? I don't think it is anything to do with male. I think it's just autosomal dominant, yeah. Good. That's ridiculous. That is a ridiculous thing to say. Like, it's so obvious. Like, you obviously. I actually don't know what happens if you have two dominant. Do you even survive that? No, yeah. Rib. Okay, let's have a look at this. AKD. Or PKD, really. Yeah, I got that one right before. Thank you very much. Tolvaptan is given. Vasopressin receptor 2 antagonist is an option. Recommended if they have chronic disease 2 or 3. Rapidly progressing. Or is like insurance provided. We're up to 42.9, guys. We're doing well. 6-year-old girl presents the emergency department with generalized facial swelling. Viral pharyngitis. Okay. Okay. Pitting edema. Face and legs. Sounds like nephrotic syndrome, doesn't it? Sounds like nephrotic syndrome. 4+ protein and no hematuria. That's high, but I don't know why high as well. Albumin is low. It is certainly nephrotic syndrome. But then the question is, oh, isn't it just prednisolone? Didn't they say that? Didn't we learn that a second ago? No, that was minimal change, but nephrotic syndrome is secondary to minimal change. Glomerulonephritis, right. Right. Yes, we're learning. Okay, I'm happy with that. It is. Oh. some septic shock. Totally possible to be septic shock, I think. Well, I went with septic shock, I'll tell you why. Hang on, I'm trying to mute something. Okay, there we go. Pulmonary embolism. You are not going to get. This is a metabolic acidosis picture, not a respiratory acidosis picture. Respiratory acidosis will come from pulmonary embolism. The rest of them, I don't even know what's going on. It's strange that not many people got that. Addison's, I mean, I'm not really sure why. Yeah, I agree. Lactate should be on there. I completely agree. It's missing a lot of stuff, but I think you can still kind of get there. Yeah, totally ridiculous thing. I actually do agree. Let's see if I was lucky. Anion gap over 14. Typically indicates. Until the patient has normal POD, indicators of bicarbonate is low, suggesting metabolic. Some effort to compensate. Okay, fine, whatever. So a lot of people with Addison's. It's weird to go straight for that. There's less acid in the blood. Cause of raised acid. I mean, that maybe I was lucky getting between those. In this case, it's normal iron. There is normal anion gap. Because people got prolonged diarrhea. How do they work out the anion gap again? The difference between the positively charged ions and the negatively charged ions. Okay, so fine. That is normal. So yeah, you add up that and that, and then you take away. Yeah, you take away that and that. Okay, I'm happy with that. I'm actually quite confused by why people struggle with that one. Considering, like, that one seems actually very straightforward compared to the other ones that I was getting wrong. And other people were getting right, is what I mean. 55-year-old man, end-stage renal failure due to have renal transplant. He is read that having renal transplant will increase his risk of cancer. Would like to know more about this. The risk of which one of the following No idea. No idea. Renal. If you have renal transplant, you're going to need to have long-term immunosuppression. Is that what he's talking about? Long-term immunosuppression. Do we go with the most common? Long-term immunosuppression. Not a clue. Not a clue. Or is it? I don't know. Myeloma. I would say. What would the immunosuppressive drugs? Those horrible ones. What do they? I had no idea. the immunosuppressive effect of the medication. Fine, yeah, I just didn't know that. Yeah, sirolimus is the one usually, isn't it? Oh, cyclosporin initially, then tacrolimus, or tacrolimus, then cyclosporin tacrolimus with MMF, what's that? Mycophenolate mofetil, okay. Sure, okay, fine. Increased risk of squamous cell carcinoma. They should minimise sun exposure. I'm sure there is some sort of thing to that, but yeah, that would have been a complete guess. I'm saying 54% of people got that right. How the hell do people know that? That seems so random. Is there like some good? Why does renal transplant immunosuppression increase squamous cell carcinoma specifically? I want it to tell me the cellular signaling reason. But that's not specifically. I want to know specifically why squamous cell carcinoma. Why? But again, it's not specific. Okay. Okay, good. Good. Increase the viral risk of HPV and EBV. EBV is associated with SCC in the nasopharynx. Good, we are understanding. Okay, fine. I'll take that. 78-year-old woman presents to the emergency department with confusion. She has a long-term catheter in situ that her son emptied 8 hours ago. Clinically dehydrated. Weighs 50 kilograms. Catheter bag contains 250 mils, so 250 mils in 8 hours. Not very much, but at least it's a bit. Blood tests, especially if she's dehydrated, that's probably. It's not alright, but. No, it's not right. Blood tests are taken compared to the 2 days ago. Urea up, creatinine up 30%. Is that where we're going with this? This is down a fair amount. Comments on injury display. What factors support this diagnosis? No, the decreased urine output is not, I would say, a good good support of AKI because she is clinically dehydrated. She's not drinking very much. Her urine output is probably low. Urine output is 250, which is bad, but that's probably because she's dehydrated. The creatinine is what you base AKI on, mostly, and she has like a 30% increase, so yeah, good. Let's see if people in more than 24 hours, in 48 hours. Okay. 26, very specific, isn't it? A 68-year-old man with chronic kidney failure has been advised by his nephrologist that he needs to follow a renal diet when he comes to learn which one of the following is usually advised by. I think it's low salt, isn't it? Not an option. It's not an option. Okay, in which case, I mean low potassium. Pretty sure. I'm going to say that. Yep. I mean, it is a So you refer with stage 3 complications, AKI of unknown cause, vasculitis and all that. 24-year-old woman is recovering from a renal transplant. Less than 24 hours after the procedure, she reports worsening pain at the transplant site. Febrile tender over the transplant has been anuric. Why is that not going to the toilet? Since procedure occurred. Do not know. I know that this is like for blood, but I don't know if that is also complete guess. I may have gone for that as well. Six months would be cell mediated. Okay. HLA typing and graft failure, human leukocyte antigen. Post-op problems, acute tubular necrosis of graft, vascular thrombosis, urine leakage, and UTI. Okay. Widespread thrombosis of graft vessels, ischemia, necrosis, and you just have to remove it. Oh, if it's within 6 months, then you are looking at C-mediated rejection. Usually it's picked up by rising creatinine pyuria, and I'm sorry, I am not a doctor. What is this? Okay, it is white blood cells in the urine. Did not know they called that pyuria. Jesus, alright, enough. You don't need to go to essay. And this can be reversible, but hyperacute rejection is not. Chronic graft failure could be either fibrosis to the transplanted kidney. The recurrence of original, so minimal change glomerulonephritis, IgA nephropathy, or focal segmental glomerular something syndrome. Maybe. An 83-year-old man was brought into the emergency department after being found on the bedroom floor by his carer in the morning. I didn't read that at all. He was last seen at 6 p.m. of the previous evening. His past medical history is Alzheimer's disease, hypertension, and benign prostatic hypertrophy. He is hypothermic, probably because he's just been out of bed the whole evening. Yeah, okay, so he's got rhabdomyolysis. What other findings but the likely diagnosis? Rhabdomyolysis, I mean, again, would it just be hypokalemia, hypouricemia? I actually don't, I really don't know. Hypocalcemia, breaking down. I mean, the creatine kinase comes from muscle tissue much sense. That is very cool. Okay, so your muscles are breaking down, it gets released into the blood, and that binds onto calcium. That's really, really interesting. That makes complete sense. And phosphate is also released, and things. These are all the other things are high because they get released by the dying cells, basically. IV fluid and urinary alkalization is sometimes, I don't know what that is. Okay, we'll finish on this one because I wanted to go to question 20 anyway, and then I'll do the other 20 questions on my own, otherwise it's going to take too long. Okay, the hematuria. We're going to have to do lots of diagnosing with very small vignettes. I hate these ones. Please select the most likely diagnosis. A 68-year-old man presents with visible hematuria. No history of pain. MSSU confirms hematuria but fails to show any organism. I mean, literally no other system, nothing else, so I don't think either of these could be this. You'd get lower, I mean, I assume they would tell us if there's lower urinary tract symptoms. I don't really know what that is. That's so rare. It's like I mean, obviously it's a renal tumour. Again, rare. Why would that first present at 68 years old? That is rare as well. I barely even know what it is. I think you get pain with this as well. Maybe other symptoms. Why would it be rhabdomyolysis? Or it's not rhabdomyolysis, but why is it? I would say bladder cancer. Loin mass. "57-year-old man, left-sided abdominal pain leading to scrotum just a fantastic looking 65%. Very happy with that. Good. Wow, I am surprised we got all those. Good. Wow, that makes me look a little bit better, doesn't it? Thank God for that. Well, guys, I hope you found that interesting. I hope you found it useful as well, some of you. I'll see you all very, very soon for the next one.